discuss a very difficult topic, the topic of opioid addiction. Sara, I'd like for you to introduce yourself.
Sure. I'm happy to be here today. My name is Sara Howroyd, as you said, and it's a real honor to be here. Nonprofits are a huge component of my life, and I was raised with a service heart, so co-founding the Manchester Hope Initiative really made sense, and I was very passionate about the subject matter.
Excellent, excellent. So tell me a little bit about your background. So
Sure.
Tell us a little bit about yourself.
Sure. So I grew up in Manchester, Connecticut. I'm the eldest of 3 children. I was raised in a Brady Bunch neighborhood, in a Brady Bunch house, and my parents were both educators. And I had one of the most fantastic childhoods a child could ever have. And I then went to Manchester High School. I did very well in school. I graduated in the top 20% of my class without putting in as much effort as I wish I had. And then I went to college at Wheelock College in Boston, Massachusetts. I got a bachelor in social work degree, graduated on the dean's list. And I most recently received a master's in social work degree Sunday, so this coming Sunday, thank you, from UConn School of Social Work with a focus area in mental health and substance use. The reason I co-founded the Manchester Hope Initiative was because I'm also a person in long-term recovery from opioids. Chief Montminy and I were actually at Manchester High School in December, and after we went and talked about the Hope Initiative, we received an email from the assistant principal saying that she was really grateful to the chief for speaking to the kids in a non-judgmental and supportive manner, because that historically this was not a support that they felt from people in his role, and that many of the kids who were present in the audience that day had parents who were either incarcerated or formerly incarcerated, or who had maybe passed away from addiction issues or overdose, and that historically these kids didn't feel that support, and that it was so moving to feel that day. So we undoubtedly have that in Manchester. And unfortunately with addiction, there's such stigma that I feel like there's probably even more than we know of that occurs. People are just taught, societally speaking, to brush it under the rug because it's so taboo in many ways.
Which brings us to a really good topic and a great segue, is that when we talk about addiction and addiction services, sweeping it under the rug also becomes a clinical treatment issue.
Right.
Right? So when you're thinking about seeking treatment, and you are not honest,
right, and
sometimes people are not honest around about seeking help,
right,
there's a huge issue there. So when someone suffers from addiction and they do not feel very comfortable seeking treatment,
right,
notwithstanding maybe treatment may not exist,
right,
where does the discussion start?
Oh, so that's a hard one. I'm a big proponent for treatment works best when you want it. That I know for me personally, what made my treatment process successful was really wanting it more than anything I'd ever wanted in my life. And unfortunately, the systems we have in place, I feel as though sometimes put people sometimes forcibly into treatment. I don't think that's always bad. I think people can pick up a lot of really good things and tools. Recovering takes a process that you need a very large toolkit for. But I think it's hard for the clinician to really fully be able to treat someone when the person's not being fully honest about things. But in most addiction treatment programs, there are drug screens. So even though some of that can be tampered with to some extent, it's hard to lie if you or be dishonest for too long. Right. But it's complicated because society teaches us to be dishonest about it in many ways, because to hide it because it's so wrong and somehow a moral or character flaw, and it 100% is not. So.
Okay, which brings us to some really good questions. So the question around about the stigma of saying that you have an addiction.
Right.
I really want to ask this question twofold.
Okay,
right? Because
absolutely.
you may come from a very solid nuclear family,
right,
in which nobody is addicted.
Right.
And it becomes an increased taboo.
Right.
But what happens if you come from a family that's all addicted?
Right.
How does that work? And you're not able to seek treatment in the right way.
Right.
When does rock bottom really happen?
Right. Thank you for those both very multifaceted questions. So the first instance that you described was my family. I came from a nuclear family. My nuclear family consisted, my dad passed away about a decade ago, but growing up, my family was a father, a mother, married for 30 plus years, all living under the same house, and with a brother and a sister.
Correct.
And that was my quote unquote nuclear family. Now, interestingly enough, since my dad passed, my family has now become more of a blended quote-unquote family over the years, but historically speaking, it was a traditional, nuclear family. I 100% think my ability to recover, I had less of adversity against me in my recovery process because I had the supports that I did. I cannot imagine how much more difficult the entire recovery process would have been if everyone around me and in my familial support network was still using. I would think that even in the nonprofit world, many people, unfortunately, might look at it, especially who'd become jaded, as it was expected that I was going to become addicted to some extent. You know,
Okay.
I mean, that when everyone around you is addicted, how could you not, kind of thing.
Correct.
And so I feel like you probably have a lot more stacked up against you. And we could unlay a whole nother level of things where I had the financial resources and assets to pay for treatment that many other people could not. And that opens a whole nother layer of things because we do not presently have accessible, affordable, respectful, dignified treatment in our region.
I do want to get at the anxiety that you feel and the peer pressure that you may feel of being a recovering addict in a family that are all addicts.
I think it would be very hard to do. I was with someone for a decade who had 3 degrees in engineering, who passed away last year.
Okay.
And the reason he and I were no longer together was because I know that I never could get and stay sober if I stayed around him. Okay. So the message in that is it's very hard to stay sober when the people around you are not. But I can't understand how much more multifaceted it is whenever it's your family. You can't just walk away from your family, right?
Why you founded your organization and what do those partnerships look like?
Right. So as I mentioned, growing up in Manchester, I was a 3rd generation Manchester resident, and I sit on a couple of councils statewide. I sit on the Governor's Alcohol and Drug Policy Council, and I also sit on the statewide opioid overdose prevention addiction work group. And so being on those councils, I'm usually up to date with legislative and policy recommendations going on in the state. And I wanted to try and sit down in Manchester and see if Chief Mark Montminy, the police chief, would equip his officers with Narcan. And anything further than that really felt like a long shot at the time. And so he and I sat down in November of 2015, and we had a very long conversation about law enforcement potentially helping with the problem. And his initial reaction was kind of, well, we're law enforcement. We are helping. We, when you're a hammer, everything looks like a nail. And,
right.
We've been arresting people for years. And I very respectfully kind of said, well, how's that working?
Right.
And he said, you have a point, Right. And now he kind of will say, I've been doing this for several decades, and if I could have arrested my way out of this problem, I already would have.
I think the chief kind of has a point. You can't incarcerate your way out of this particular issue.
Right.
But I want to go back to thinking about how important getting Narcan is
right.
in terms of not only the law enforcement issues, but in terms of the first responders, EMS, fire, all of those things, because they seem to be responding to overdoses in record numbers.
They 100% are.
Right, so,
and I'm even going to go a step beyond that and would push people who have a loved one who takes opioids, maybe who isn't even quote unquote abusing it or dependent. We really want for everyone to have Narcan in their house. Everyone. The same way we would have a fire extinguisher, you can buy it without a prescription at most pharmacies in the state of Connecticut. The Department of Mental Health and Addiction Services has a website where you can locate every pharmacy provider within the state of Connecticut Most insurance plans, you can go and it's paid for through insurance. You might pay a copay. There are instances at the Manchester Hope Initiative where someone maybe has financial need. We do have some in stock that if someone really needed it, we are happy to try and give it to them. There are other harm reduction agencies around, but it's really imperative, especially if people are at higher risk of overdosing, that their loved ones have Narcan. And what that looks like is for people who just exited prison, people who have overdosed in the past, the likelihood of overdosing again goes up higher and higher. I work with parents who have lost children to overdose.
Right.
And some of them have become friends and colleagues, and they will say to me, in hindsight, stigma prevented them from asking their doctor for Narcan. But had they, their situation would be different.
What is opioid?
So opioid is an umbrella term that covers the gamut of all things deriving from opium and or synthetics. So heroin, fentanyl, carfentanil, Oxycontin, hydrocodone, Vicodin, codeine, and the list goes on.
Now these drugs are prescription drugs?
Largely, yes.
Given to pharmaceutical companies? Okay.
Yeah, so from pharmaceutical companies.
From pharmaceuticals, right.
Usually written from your doctor.
Okay.
There is a newer black market we're seeing of fentanyl and carfentanil being bought on the street that's coming in from Asia.
Okay.
But largely what we saw is kind of the catalyst of sparking this whole reemergence of heroin and or other opioid addiction was Oxycontin.
What would be some of the purposes a doctor would write it for?
Absolutely. So when these came out, and again, I'm not a doctor, but I do know quite a bit about this, the mindset was palliative care, end-of-life care, extreme pain. And when I say extreme pain, I mean pain that you are in so much pain, you're probably being rude with the person providing it because you are in such extreme pain, excruciating pain. And unfortunately, in the mid to late 90s, pharmaceutical drug companies realized that they could make a lot of money. And so they started soliciting many primary care providers with no experience in pain management. This is not something that medical schools have taught up until very recently.
Correct.
And I believe right now only 3 are teaching it, if I'm right. Okay. And I mean, I have a friend who graduated from Harvard Med less than 10 years ago who will argue with me that addiction's not a disease. So I'm just saying, it's hard.
So there's multiple philosophies.
So there's this huge surge in overprescribing. And there wasn't a lot of conversation of, is this addictive? Because at the time, the doctors were being told it wasn't addictive. When I asked my doctor in 2005, I was told it wasn't. My Ivy League educated doctor told me it was not addictive. I unfortunately was put on it after a horrendous car accident, but in hindsight, it was not the appropriate treatment intervention.
Okay.
And so if doctors were freely prescribing, and I don't want to fully blame doctors because I feel like the pharmaceutical drug industry really kind of pulled one on them. You know, I mean, I feel like that they were unfortunately kind of urged in a certain direction that wasn't fully founded.
For pharmaceutical companies to recoup their costs from research and development, there's this way here, right?
We need to be having further discussions. SAMHSA, Substance Abuse and Mental Health Administration, or federal government, put out new opioid prescribing guidelines for providers. And I would urge them to look at it, because again, I'm not a provider, and I know that MDs don't like non-MDs telling them what to do.
Correct.
But I would urge them to look at this, because there is a lot of discussion of people's history. Do you have a history of substance use?
Correct.
Is it in your family? What else are you taking? And when I do prevention work with kids, I always say, whatever your doctor puts you on, have this conversation about how long am I going to be on this? Will it be hard to go off of when I do try to go off of it? And what's our game plan? But one other thing I wanted to add, when you talked about the insurance industry, from a policy standpoint, we're kind of starting to, I don't want to say stir the pot, but talk to these insurance providers, and they're finally becoming aware of how much money they're doling out in regards to the opioid epidemic.
Correct.
And their awareness, I think, we're going to see some changes coming down the pike.
The Centers for Disease Control determines this to be an epidemic. And if you just go on the Center for Disease Control website, you're going to see that opioids include prescription opioids and heroin killed more than 33,000 people in 2015. More than any year on record, nearly half of all opioid overdose deaths involve prescription opioids, right? So this kind of validates this. Second, they also say that improving the way opioids are prescribed through clinical practice guidelines ensure that patients have access to safer, more effective chronic pain treatments while reducing the number of people of misuse, abuse, and overdose. First of all, the doctor shopping piece. So when an individual is actually addicted to an opioid, right? And it could be that definition of the cocktails that we just talked about, correct? What happens is that they may not get enough of that prescription in one specific doctor.
Right.
So what they do is shop around.
Go to another doctor.
Go to other doctors. So tell me a little bit about how that works.
Okay. So that's very common. The same way a lot of the people that I work with, and I believe this is Chief Montmany's stat, but he'll say about 80 to 85% of the crime in Manchester is in some form attributed to some form of drug addiction, whether it be opioids or other. When people are in the midst of this, there is self-responsibility, but it becomes very uncontrollable, and usually, especially with opioids. And so a lot of the larceny, stealing checks from maybe your family, shoplifting, the gamut goes on. So part of his mindset with integrating this program was in a hope of reducing crime. But it becomes a compulsion. And so while it may sound, even for me, as someone who's far removed from this situation for several years, kind of like, whoa, you did what? You went to multiple doctors and you found it. My part, I believe that professionally, we need to be enforcing our prescription drug monitoring program. Okay. And I recently had a conversation with my own PCP. We know that Connecticut right now is going through a fiscal crisis. So my primary care provider, I was talking to her about how this prescription drug monitoring program. So in the state of Connecticut, all prescribers, so doctors, physician's assistants, APRNs, everyone who can write a prescription, when they write an opioid prescription, is supposed to be checking this system, a universal Connecticut system. So if, say you have an opioid prescription, your doctor goes to write it, she's going to make sure you don't have 5 others at 5 other doctors. Right. The problem is my PCP recently mentioned, my primary care doctor recently mentioned to me that it's not enforced. The state doesn't have the money to enforce it. So if no one's enforcing the doctors to do it, this whole system that's very expensive for us to have, we can't always take things on the goodwill. So I think legislatively, we need to move to have a consequence to not check that.
But the enforcement part, that's really hard.
Right.
That's really, really hard.
And maybe the word enforcement isn't right. Maybe fines. Usually money motivates people. I'm not talking about taking away someone's life.
Punitive types of things.
Well, right. But what my doctor was basically saying was, yes, I use this, but most doctors don't because there's no consequence if you don't, is basically what she was insinuating. Correct. And so if we're spending millions of dollars to have this program, it seems really counterproductive to me. It's like, why even have it if we're not going to have some consequence?
As the opioid epidemic starts to increase in nature, right, access becomes less and less. Right. Therefore, crime is going to be on the rise due to the fact that the addict may not have any other way to do it. Well, right. Correct.
And these are usually historically people who, I mean, I don't know the exact statistic, but I would guess 9 out of 10 people who are committing these crimes while addicted to opioids, when they weren't on opioids, had never had a criminal history. I would venture to say that these are not people who have ever committed crimes outside of, I'm not giving them a get-out-of-jail-free card. And Chief Montmany says this all the time. No one can rob a bank and say, I'm going to the HOPE program. It doesn't quite work like that. We have some things where you need to work out your legal issues, and it's not just a get-out-of-jail-free card. You have to be committed to getting well. But I largely believe a lot of these people, the treatment is the solution in these cases because we can often turn it around so that they're paying taxes and working and being proactive parents, and all other systems are being depleted by the cost of this epidemic.
Right. So tell me a little bit about how the program works.
Sure. So the HOPE initiative, at any time, there's kind of 2 different channels. It's a law enforcement facilitated community diversion program. As I notated, it's not a get-out-of-jail-free card. Someone, they're still going to go after the high-level dealers, people who are making huge profits off of drugs. They 100% are still enforcing. Mm-hmm. But if you suffer from opioid use disorder yourself, and you want help, and you walk through those doors, 100% of the time they will help you. If you walk into the Manchester Police Station and you say, I have an opioid addiction, I want help, They will help you, no questions asked. You have works, you have needles, you have anything on you, they're going to basically point you over, have you dispose of it, and that's it. You're not charged with anything. It gets kind of complicated if someone has a plethora of warrants. They're going to have to work out those issues.
Right.
But I will say, again, not being a judge, the same way I'm not a doctor, I would imagine it would look good to a judge if someone was like, I went through Manchester Police's program, I completed treatment in that regard. The other way that someone can come into our program is Chief Montminy gave his officers the discretion where, depending on the circumstance, if someone has a minor possession charge, okay, so up until about a month and a half ago, if you had an empty bag of heroin with just residue, that was a felony.
Right.
So even if you had your personal use, right, and even just residue, no real substance left, that's a felony. So if this person, like I mentioned, who had never committed crimes before, is now charged with a felony, and they go into treatment and get well, what does their outlook look like for job opportunities, for everything else? But so Chief Montminy is giving his officers discretion that when they feel appropriate, they can offer them treatment instead of arresting them. The DA is on board, Adam Scott. He was hugely supportive of this because we're finally starting to, as a community, see addiction for what it is, a chronic, relapsing, reoccurring disease. The same as asthma, the same as diabetes. The board of directors is on board. We utilize ECHN right now in town. They're our hospital, and so basically the police will bring them down to the hospital. They're our clinical gatekeeper. Anyone can also walk into ECHN if need be and avoid the police department if they like, because that's kind of a taboo thing. A lot of people, especially who maybe have been misusing substances, may feel like going to the police department is an off-kilter kind of idea.
Right.
They can go right into ECHN and get help as well.
Okay. As you talked about how Manchester deals with, he's allowing the police force to make a discretion call
Right.
around about,
Yep.
you know, instead of having a felony conviction,
Right.
we really think about that.
Right.
For people that are not on board with that,
Yeah.
you end up with a felony conviction in a particular type of demographic in an area,
Right.
right? And it talks about what you just mentioned. What is my hope then?
Right.
Right?
Yeah.
I know Connecticut was very, very aggressive in, I think in the past year or so, implementing, you know, the second chance type of activity to
Right.
allow individuals that are coming out of prison that are convicted
Right.
with a felony to be reintegrated into the community
Right.
with this non-biased type
Yeah.
of activity, because it does become an economic burden. right?
Absolutely.
So what would you say to them? Do you think that there is a play to that? Do you think that, you know, you would see incarceration in one population that doesn't adopt it as opposed to another? And what is your experience with that?
Well, as far as Chief Montmany's mindset, and I can't speak for him, although I often do. No, he says that jokingly. No, but I believe his mindset was that he didn't want to tell his officers starting off, this is a black and white rule. This is how it's going to be. You're going to let all heroin addicts off.
Right.
He wanted it to be discretion so that his officers still had the power, so that if this was someone they saw the 12th time that week, and maybe they let them off for the HOPE initiative 4 times before that week,
Correct.
maybe that would still be the appropriate intervention. I believe that was more so the mentality, that the Manchester Police Department may not be receptive to this whole initiative
Right.
if he came in saying, you're going to let all the heroin addicts walk. And so he wanted to keep that so that it was, because every situation is going to be different.
Correct.
Everything is going to be a case-by-case basis. As far as second chance society, I think it's really, really important, because we can't expect people to turn themselves around, fight against all the odds, live past something that they were not supposed to survive, maybe put themselves back through school, walk there with a head high, to have to go explain a criminal record,
Right.
to then be, you know, maybe after 10 years of still doing well and no criminal record.
Right.
It's really sad.
Right.
And then furthermore, like with your program, what kind of impact does that have on the kids? You know,
Correct.
because at the end of the day, you and I were talking about this previously, people's children are the ones who suffered the most dire consequence
Oh, I
of this
agree.
whole entire epidemic,
I agree.
you know?
Let's start talking about some leadership challenges.
Sure.
Right. So what were some of the challenges that you faced when you were forming this nonprofit
Yeah.
organization? So tell me how you kind of solved some of those. What were the challenges? How'd you solve them?
Absolutely. So remarkably, Manchester as a whole, meaning the community, the board of directors, the town manager, Chief Montminy, everyone was hugely supportive. I'm going to get teary-eyed, but like it was honestly the most beautiful thing. And no, it really was. I was expecting a lot of blowback, and there are some neighboring towns that would not have been as opening arms. There's more of a mentality in some surrounding areas, not naming any, that are more like, we don't have a problem, what are you talking, you know? And we all know that every town in this state is not immune to this.
There's 169 cities and towns within the state of Connecticut. One at a time, right?
Yeah.
So,
no, but all 169 had at least one overdose death last year.
Which is huge, right?
Right,
so
right.
you're thinking about a state that's got X amount of numbers in it, and
Right. So I would say and I don't want to speak too negatively, but our biggest challenge was finding a partner who could offer a quick, easy, respectful, dignified, humane access to treatment.
Correct.
We tried high and low. I mean, we had so many people who were willing to help us, but it was really hard to find that beeline. And the window when someone, especially with opioid addiction, wants to get well is very small. If it's Friday at 10, they're not going to wait until Monday at 9 in the hospital.
Yeah. When we think about the hopes, right? So we think about the hopes of this program, and from what I hear, it sounds amazing. How does that translate into a Hartford or a Bridgeport or a Chicago? Or, you know, so what are your thoughts around about that? So,
without saying too much, maybe some of the areas you mentioned are actually in talks to maybe do something similar. I don't want to announce anything because I don't think anything's finalized, but I think that, let me say this, I think that other towns and cities are definitely noticing what we're doing. Chief Montminy and I had a conversation almost 2 years ago, or just under 2 years ago, and we were like, we spent thousands of hours on this, like literally not even an exaggeration, because we knew that if we did this and it fell, no one else would ever touch it for a very long time, if ever. But if we got it to a place where it succeeded, everyone would want to do it. And so we knew going into this that. And so I will say that from what I've heard, because Chief sits on the Connecticut Police Chiefs Association, many other towns are watching with an open ear, requesting policies. I will mention there's the Police Assisted Addiction Recovery Initiative, which was birthed out of the Gloucester, Mass initiative.
Correct.
Which our program is loosely based off of. They were the first in the country to start this. They have a plethora of resources for anyone in the law enforcement community who wants to see policies of how these programs are implemented. From Santa Fe to Seattle, a lot of places nationwide are tweaking it to their community's specific needs.
Okay.
So like some people are, when there's an overdose, sending out a clinician following to kind of do some outreach and say, hey, have you thought about treatment options? There's many different kind of spins to it, but it's a good resource to know about.
This program is really, really powerful. You know, we've talked about how the opioid epidemic is growing. So tell me a little bit about how the program could grow into other states, and let's think about that for a little bit.
Absolutely. So there are some other states right now that are doing some things that are similar, but because of my nonprofit background, I was very mindful going into this program of data collection, because problems don't exist without data, and with the mindset of hopefully, if it worked, making it into an evidence-based practice model. So UConn School of Social Work is actually on board to do our data collection and is really helping guide us. We applied for grant funding with the Arnold Foundation to see if they can help us to make this program easily implementable in other areas. But Chief Montminy and I are also very happy to help anyone else who's interested to do this. This is really a passion project for both he and I. It's all about getting people and families and communities help. So anyone who wants help with it, you know, he's happy to offer policy, and I'm happy to offer direction. Some places up in Boston, south and north and west of Boston, are presently doing it from Gloucester. But we're happy to share any knowledge that we have with any law enforcement agency that would like to do this. we're working out the funding aspects of things
Correct.
too. We just got our 501 status.
Takes a
officially.
while.
It does.
It takes a while.
Well, I did it, state and federally, and I did it all alone, and we finally got it. So now it's going to open this whole new avenue of fundraising possibilities because, again, without speaking too negatively, we've had to send some people out of state for treatment, which is really sad and frustrating. But we're realizing that in some cases, we're going to need to do that. So that's on the horizon. But I also, since we've been in the press a lot, I can't tell you how many beautiful people have reached out saying, I'm an addictions counselor, I'm a nurse, I'm a therapist. I'm none of those in-kind professionals, but I want to volunteer, I want to volunteer. I'm hoping to really utilize a lot of those volunteers. And most excitably, we've heard from a lot of loved ones in the community who are saying, you guys think there's nothing for people living with addiction. There's really nothing for families and aunts and fiancés and grandmas.
Correct.
And there's nothing, and outside of a couple support groups that, in the area. So I'm working with a couple of people, and we're going to be launching an arm actually next Wednesday at the Manchester Police Department from 6 to 8, and it's going to be called Hope for Loved Ones. We're going to
I'd like to get involved in that.
Absolutely.
That sounds fun.
Let's talk.
Sounds fun.
It's going to be a drop-in resource center where there's going to be a lot of people who've been through it, loved ones who maybe have a child who has suffered from addiction, who can guide the person in the right way. Say maybe, here's some legal advice or, off the record, kind of what would you do with this? Here's some treatment. Here's all types of resources.
So this is a really difficult question, and I hope some healthcare payers are paying attention. As we move to a value-based care model, and we understand under the Affordable Care Act, we think about how population health management actually works. Programs like this is exactly what we're trying to get after. When you think about the value-based in medicine, if you're able to treat opioid addiction and provide all of the wraparound services, in the end, there's a cost savings. So even though the upfront cost may be a significant amount, the savings on the back end is absolutely amazing.
Huge.
So I would love if any of the payers are listening to this, come out and really see this initiative and understand how we can figure out what the funding reimbursement really looks like to add a value add types of payer pieces, because it's important. Not only the addiction services that you actually have, but the wraparound services that you plan to have in the future.
100%, and I really appreciate that. I felt very strongly going into this. We do have a component that I neglected to mention. We have a grant funded by, well, we don't have the grant. CCAR has a grant with DEMIS. So it's Connecticut Community for Addiction Recovery.
Okay.
They have 4 different recovery coaches throughout the state that are in hospitals. Because our treatment system is so fragmented, historically people who are trying to enter treatment get stuck in the ER. Sometimes that behavior, as someone starts to withdraw, may not be the best to be around. But apparently, people are loving having these recovery coaches on site who been there, done that, have been extensively trained, and can kind of guide the person through the process. It's not fully like case management, but it's not totally like a sponsor. It's kind of a... It's
a tweener. It's in between.
It is.
It's more than a coach and less than a sponsor.
Right.
More than a coach and less than...
Yeah. It's pretty amazing concept. But having them on board is really amazing. But I will say, too, as far as cost effectiveness, so many systems are being burdened by this opioid epidemic and all addiction epidemics, from criminal justice system to imprison someone. It costs, I believe, $59,000 a year, maybe more. So that alone, anything you do is going to be much less than that. But then healthcare systems, the emergency rooms, the amount that we're paying in care in ERs is astronomical. Law enforcement, education, so many systems are being burdened by this.
So as we think about that, it's really good. So as we move to an accountability care organizational type of model, and I think as people really realize the consolidation of all the hospitals like Hartford Healthcare and things of that nature that are moving and adopting this ACO type of model, the urgent care centers, which are now taking a slack of kind of like ERs, right? You don't want people to go to the ER for sniffles and colds. I think that this particular type of model may work if we partner with urgent care centers to provide some of the sort of the coaching. So I'm very positive and hopeful. I mean, I listen to what happens with your organization, and I wish you well in the future.
Thank you. I
think
appreciate
it's
that.
absolutely amazing.
Thank you.
So a couple things that we kind of wanted to wrap up. The first thing I think would be is that as we think about scale and scope of this program,
Right.
the services that have to be provided for families is so extensive.
Definitely.
And do you see technology playing a role in any of this, or does it really have to be a face-to-face type of activity or a blended type of an approach? It could be both. What are your thoughts on that? What do you think?
I'm open-minded.
Okay.
This was such a passion project for me that if it makes sense for the mission of the program and the people, the individuals, families, and communities it serves, I'm all for it.
Okay.
And I think technology is going to be a really big part of all nonprofit and human service components moving forward. I really do. I'm open-minded to it if it makes sense.
How does mental health play in this?
Mental health hugely plays into this.
Okay.
75% of people with addiction issues usually have a co-occurring mental health issue. Sometimes undiagnosed, sometimes misdiagnosed, and often they're self-medicating.
Mental health such as?
Such as, I mean, it could be a gamut of things from an eating disorder to ADHD to depression to schizophrenia to bipolar disorder to, I mean, across the gamut. And sometimes there will be multiple diagnoses.
Would some of these individuals be diagnosed or undiagnosed? Because it goes back to our original, when we opened up the show, we said some people really are not going to seek treatment.
Right.
So they may be exhibiting these particular types of
100%.
behaviors and go undiagnosed for a long period of time, and there could be a misunderstanding about why these individuals are behaving this way.
Definitely. And that's so important that you mentioned that. It's multifaceted because there are times when people can get a misdiagnosis when they're using alcohol or other substances because those issues are mimicking other mental health issues.
Okay.
And there are times where maybe someone's suffering from severe depression and their family is like, you're being lazy, you're not doing this, you're not doing that, but it's really a deep depression that could be properly handled with medication or therapy or whatever they decide with their doctor, and they're probably self-medicating to make that go away.
Wow. On a personal level, did you suffer any of those things when you actually had the car accident and you were trying to recover? Do you want to share if you're okay with that?
Absolutely. So I, in hindsight, suffered from those things long before my car accident. I had an eating disorder, I have ADHD, I always had really bad anxiety. But they were at bay, and I was in that nuclear family that was very structured and very supportive. I really do think that that helps. And so maybe even down the road doing kind of like what you do with your work, really supporting kids and young adults going through this, I think is going to be really important for the recovery process. But for me, part of what keeps me in recovery is therapy and, you know, some non-addictive pharmaceutical medications and constantly seeing a doctor, working out, eating healthy, giving back to my community is a really big part of my recovery process. But I look back in hindsight, and it was definitely a big part of it.
Okay.
I think you might have if you have those issues, you might have a higher propensity for addiction, if it's not properly dealt with.
So really good question. So as we begin to look at the generations, right?
Yep.
So we look at the baby boomers, we look at the Gen Xers, and we look at the millennials, right? So they're all out there. The way that they engage in their quality of life is different in each one of the generations.
Definitely.
So what I hear from you is that you really need to get back to kind of basics, right? Get back to engaging with your friends. Get back to being positive and giving back to your community. Being able to be engaged in a positive manner is so fundamental to your health. And the health that we're talking about is not just your physical health, but your mental health as well.
Definitely.
So it resonates with me when you talk to me about, you know, being able to really enjoy your life, right? You know, there's certain types of things that you can change, and there are certain types of things that you cannot change. Right. So what we're trying to do is throw all the factors that you can't change and deal with the things that you really can change.
Definitely.
Right?
Definitely.
So when we talk about issues of eating disorder and peer pressure and dealing with all those things, some of those things are kind of quasi-stress related, right? So if we're able to deal with the factors that cause stress and get back to, I would say, some parts of Europe.
Right.
You would think about how they live and what their quality of life is.
Right.
I'm not going to talk about their debt structure. That's a totally different ballgame, right?
Definitely is.
But being able to enjoy life is so important,
It is.
especially around about this very fast-paced environment
Definitely.
of instant gratification and being able to have a good conversation with
Right.
somebody. And is there any closing remarks that you would like to talk about or things that you would like to do?
Sure. Well, I appreciate what you just said, because I believe that recovery really has to be a holistic process. I believe there are so many things that we aren't practicing: mindfulness and meditation and working out and eating healthy. And the biggest one, the opposite of addiction in my mind, is 100% human connection.
Right.
And so that is a big takeaway. But I also really too want people to know that recovery is possible, and there is help out there, and that people can get help, and that it's never too late to try again. It never is. And at the end of the day, I want people to know they're not alone, and that help is out there and recovery is possible.
Absolutely amazing. And one last note I think I'd really like to talk about is alternative medicine.
Definitely.
So as we begin to think about, we're always so fascinated with treatment providers in a certain way.
Right.
Right. How do we deal with alternative medicine when it comes to addiction?
Right.
Where does that come to play?
So, ironically enough, there's a really great resource, Toivo, in Hartford on Franklin Ave. It's part of Department of Mental Health and Addiction Services funds Advocacy Unlimited.
Okay.
And Toivo is 100% holistic. They have Qigong, they have mindfulness, they have meditation. It's totally free. It is amazing. I could not recommend it anymore. And even if you just go to check out the classes, they have yoga, and everything about their program is holistic, alternative medicine. They have conferences. I've learned more from them than anyone else. They're really amazing over there in regards to alternative medicine.
Excellent. I'm not that flexible. But thank you very much, Sara, for joining the nonprofit world. It was excellent having you, and I really wish you well.
Thank you so much. I appreciate it.
Prescription opioids are a type of drug used to manage pain. They include OxyContin, Vicodin, and morphine, among others. Some people might think prescription opioids are safer than alcohol or illegal drugs, but the truth is they carry serious risks and side effects. In fact, anyone can become addicted to prescription opioids, even when prescribed by a doctor. Abusing or misusing opioids can result in loss of control. It can affect your ability to keep a job and maintain healthy relationships. It can even lead to overdose and death. Prescription opioids can have a number of side effects, even when taken as directed. Some of those include physical dependence, increased sensitivity to pain, constipation, nausea, confusion, and depression. You can make informed decisions about your pain management. Talk to your doctor about non-opioid options like ibuprofen or acetaminophen, antidepressants, exercise, and other therapies. If your doctor prescribes opioids, ask how long you'll need to take the medicine and how you'll know when it's time to stop. Take only the amount prescribed. Talk to your doctor about all of your medications. It's very dangerous to combine opioids with certain other drugs. Talk to your doctor about all of your concerns. Follow-up is important. To learn more, go to cdc.gov/drug overdose.
On a scale of 0 to 10, 10 being the worst, how would you describe the pain?
Probably an 8.
As far as my general activity, well, the pain makes it hard to get the job done at work.
We can try an opioid at a low dose, but it's very important to understand the risks. Everything from constipation to addiction and overdose, even fatal overdose. When opioids are used, They work better when they're used with other treatments, like exercise. Well, I want to check back in 3 weeks and see if you're meeting your goals for pain and function. How are you doing?
Pretty good. I can even pick up my eldest granddaughter now.
Doctor, thanks for seeing me. I think I need to fill my medication early.
Sometimes it can be difficult controlling how much medication you're taking for pain, so let's talk about medication and lifestyle changes to help you meet your treatment goals. Every patient is different, but opioids pose risk to all patients. Refer to the CDC guideline for prescribing opioids for chronic pain to minimize your patient's risk.